Hello, everybody. My name is Lauren Pripsfeld. I'm a clinical dietitian at the Michael E. DeBakey VA Medical Center in Houston, Texas. Today, I want to present a case study to you on a patient that has Crohn's disease, complicated by an enterocutaneous fistula. At the end, we'll talk a little bit about micronutrient deficiencies in patients on long-term home parenteral nutrition. So let's go ahead and get started. I want to present to you Mr. M. He is 51 years old with a past medical history of stricturing ileocolonic Crohn's disease. Mr. M has sustained multiple abdominal surgeries over the course of his disease, and most recently, he has developed an enterocutaneous fistula requiring a chronic wound vac. So I want to take a few minutes just to talk about the pathophysiology of stricturing Crohn's disease. Crohn's disease is a type of inflammation of the intestine. The inflammation often shows up as ulcers that can become deeper and larger with swelling and irritation around them. Eventually, the ulcers may progress and the swelling in the bowel can become so tight that the bowel narrows and blocks the flow of gastric contents. This narrowed area is called stenosis. Once areas of bowel stenosis form scars, then these scars are called strictures. The strictures can become very painful and sometimes require operating to remove that section of the bowel. Another way that Crohn's disease can progress is that tracts can form from the intestine to the skin, and this is called a fistula. So unfortunately, Mr. M has stricturing Crohn's disease, which means that he had to undergo several abdominal surgeries to remove the strictured portions of his bowel. So Mr. M's usual body weight is about 215 pounds. But over the course of the year, when he was undergoing these bowel resections for his stricturing Crohn's disease, he lost about 30 pounds. He also developed a fistula during this time that was covered with a wound vac. We placed Mr. M on TPN due to his ongoing weight loss and minimal oral intake due to his abdominal pain. He was also malabsorbing a lot of food that would come out of his fistula. He self-limited his oral intake to reduce his fistula output. He was actually seeing whole chunks of his diet in his fistula. So he really was limiting his oral intake as well. So many reasons we put him on TPN. And also he was having to change his wound vac several times per day due to the high output. So what did we prescribe for his TPN? Let's look at his anthropometric data. His height is 75 inches. His weight is 188.9 pounds or 85.9 kgs. His ideal body weight is 196 pounds, so he's underweight. Next, we calculate his baseline predicted calorie and protein needs. I used 86 kilograms. For calories, we calculated 2,150 calories to 2,580 calories, which was 25 to 30 kcal per kg. For protein, I used a 1.2 to 2 grams per kg range, which calculates to 103 to 172 grams of protein. And then for fluid, I used 1 ml per kcal, which calculates to 2,150 to 2,580 milliliters per day. Okay, so let's look at how we're going to calculate our TPN for Mr. M. I'm going to start with total volume, which I'm going to want to use 2,500 mils. 2,500 mils per day is going to meet the upper end of Mr. M's fluid range that I calculated when I was calculating his needs. So with that in mind, I have a total volume of 2,500 mils that I want to reach. Now we have to break that down into mils of dextrose, amino acid, lipid, and sterile water. So we're looking at a 3-in-1 solution for Mr. M. So the pharmacy that Mr. M works with uses a D70% solution, a 15% amino acid solution, and a 10% lipid emulsion. So to start the breakdown, I'm going to look at dextrose first. Usually when we start a patient on TPN who may be at risk for developing refeeding syndrome, the rule of thumb is to start with 100 to 150 grams of dextrose in the bag. I'm not too concerned about refeeding syndrome for Mr. M just because he's been eating and absorbing a little bit. So I'm going to go ahead and start with 200 grams of dextrose, which is on the low end of what his goal would be. So if I use 200 grams of dextrose and divide by the concentration, which is 0.7, then I'm going to get 285 mils of D70. You can take the 200 grams of dextrose, multiply by 3.4 calories per gram, and get 680 calories. Next, I'm going to pick how many grams of protein that I want in the TPN. You can go ahead and start with goal protein if the patient's renal function is normal. Mr. M's renal function is normal, so I'm going to go ahead and start with goal protein, which is about 100 grams, based on his calculated needs. So if you take 100 grams of protein and divide by the amino acid concentration, 0.15, that gives you 667 mils of 15% amino acid solution. You can take your 100 grams of protein, multiply by 4 calories per gram, and get 400 calories. Next, we're going to look at lipids. So I know that I want 50 grams of lipid in the bag. I'm going to divide it by the concentration, which is 0.1, which gives me 500 mils of lipids. And finally, you take your 50 grams of lipids, multiply by 10 calories per gram, and get 500 calories. So if I add these mils of dextrose amino acid and lipids together, I get 1,452 mils. If I take my total volume of 2,500 mils and subtract the volume of the macronutrients, which is 1,452 mils, it gives me 1,048 mils left over. I can make up the rest of this volume with sterile water. So I'm going to recommend 1,400 mils of sterile water in the bag. If you add up the calories from all the macronutrients, you are going to get 1,580 calories. And then of course you have 100 grams of protein. So this is the first prescription that we started Mr. M on. A few weeks later, we check on Mr. M. Unfortunately, Mr. M continues to lose weight despite increasing his oral intake. We assume that he's malabsorbing most of what he is eating due to the nature of his enterocutaneous fistula. So we move from meeting kind of the lower end of his estimated needs to the higher end of his estimated needs. Okay, so over the course of the next several weeks, we increase the dextrose content of Mr. M's TPN from 200 grams to 300 grams and then again to 400 grams just because he continued to lose weight. Again, we increased the protein content along with the dextrose content from 100 grams to 125 grams and again to 150 grams. And finally, we also increased his lipids over the course of these several weeks from 50 grams, again to 60 grams, and then again to 70 grams. So I want to show you the breakdown of calculations for the 400 grams of dextrose, 150 grams of protein, and 70 grams of lipids that are in Mr. M's 3-in-1 TPN solution. So if you take the 400 grams of dextrose, divide it by the concentration, which is 0.7, you get 571 mils of D70. You take your 400 grams of dextrose, multiply it by 3.4 calories, you get 1,360 calories. If you take the 150 grams of protein divided by 0.15, you get 1,000 mils of 15% amino acid. You can take your 150 grams of amino acid, multiply it by 4, and you get 600 calories from amino acid. If you take the 70 grams of lipid and divide it by 0.1, you get 700 mils of lipids. And you can take your 70 grams of lipids, multiply it by 10 calories per gram, and you get 700 calories. You also have to take into account what you want your total volume to be. For this particular situation, Mr. M had 1 liter of normal saline available to him, PRN. So whenever he felt dehydrated or like he needed extra volume or his fistula was putting out too much volume, he was able to infuse 1 liter of normal saline. So because of that, we kept our total volume at 2,500 mils around. Actually, on this round, he came out to 2,571 mils just because of the way the macronutrients worked out. For the most part, we've kept the total volume the same throughout the subsequent weeks and months because he had the prescription for the normal saline 1 liter PRN. So we took our total volume, subtracted our macronutrient concentrations, and added 300 mils of sterile water to come up with the total desired volume of about 2,500 mils. If you add up those 3 macronutrients, the total is 2,660 calories and 150 grams of protein. So despite feeding Mr. M 33 kcals per kg and 1.7 grams per kg of protein, he unfortunately continued to lose weight. His weight got down to 165 pounds or 75 kgs from 189 pounds. We didn't really have much of a choice other than to increase his macronutrients even further. And I will say, as we were making these adjustments week after week, we were monitoring his liver and kidney function to make sure that we weren't stressing out his organs. But this whole time, his LFTs remained stable and his renal function remained stable. So we felt safe increasing his calorie and protein provisions in his TPN well above his estimated needs. So if you look at re-estimating his needs, we used 45 to 50 kcal per kg, which came out to 3,375 calories to 3,750 calories. We used 2 to 2.5 grams per kg of his weight, which came out to 150 to 188 grams of protein. And then for fluid, we used 1 mil per kcal, which resulted in about 3 liters to 3.3 liters. So if you look at the calculations, we increased his macronutrient content to 535 grams of dextrose, 185 grams of protein, and 75 grams of lipids. So if you start with your total volume that you want, which now is about 3 liters for us if we want to meet 1 mil per kcal. We take 3 liters and then we have to break that down into mils of dextrose, amino acid, lipid, and sterile water. So let's look at that calculation. We want to increase Mr. M to 535 grams of dextrose. You divide that by the concentration of 0.7, you get 764 mils of D70. For protein, we wanted to increase his protein provision to 185 grams of protein. Divided by the concentration, 0.15, you get 1,233 mils of 15% amino acid. For lipids, if you take total lipids, 75 grams, divided by the concentration, 0.1, you get 750 mils of lipids. So if you add the total mils together of macronutrients, 764 of D70 plus 1,233 mils of 15% amino acid plus 750 mils of lipids, you come up with 2,747 mils. Then you can take your total volume, 3 liters, subtract the 2,747 mils, you're left over with 253 mils left, which can be made up with sterile water. And if you take your calculations, you can figure out the calories from the solution. I won't go into the math, but it'll be on the screen. The total calories from the solution is 3,309 calories, and the total protein was 185 grams of protein. Now, this is a lot of calories and protein, but finally, we're happy to report that Mr. M started gaining weight on this TPM prescription. So it took a lot of trial and error for us to figure out what macronutrient concentrations would finally help Mr. M to stop losing weight and finally start gaining weight. And this was our answer. So ultimately, meeting 45 to 50 kcals per kg of his calorie needs and 2 to 2.5 grams per kg of his protein needs put him on an upward weight trend. Okay, now I want to move into a little bit about micronutrients in patients receiving long-term parenteral nutrition. So we're going to look at one of Mr. M's hospital admissions where he was admitted for a GI bleed. So I saw Mr. M while he was hospitalized for his GI bleed. During my assessment, he complained of peripheral neuropathy and pain in his muscles and bones. Our micronutrient-focused physical exam also revealed pale skin and quillinica, which is spoon-shaped nails. So because Mr. M was on long-term parenteral nutrition, I requested a baseline ferritin, TIBC, which is total iron binding capacity, a vitamin D 25 OH level, an RBC folate level, vitamin B12, vitamin E, vitamin A, zinc, copper, selenium, manganese, and CRP. Now, these are routine labs that you'll want to check at least every 6 months while someone is on long-term PN. As I suspected, Mr. M had low levels of ferritin, which indicates an iron deficiency. Mr. M also had deficiencies in vitamin D and vitamin E. Now we are tasked as a dietitian in what to do for these micronutrient deficiencies in Mr. M. So first, let's look at treating an iron deficiency. Iron supplementation should not be undertaken without identifying the cause of an iron deficiency first. Dietary recommendations are to increase food with high heme iron content, such as recommending someone to consume animal sources of iron, such as meat and poultry and fish. Also, heme sources of iron are better absorbed than non-heme sources. Foods that you can eat to enhance iron absorption are vitamin C, fructose, and citric acid. Foods that you might consume that would inhibit iron absorption are things like legumes and grains, rice that have phytic acid in them, polyphenols such as coffee, tea, wine, and spices, soy protein, oxalic acid, tannins, phosphate, and fiber. There are several commonly used oral iron supplements and commercially available IV iron products. For Mr. M specifically, he received 510 milligrams of IV iron with monthly maintenance doses as needed based on his ferritin levels. So next, let's talk about treating the vitamin D deficiency. So you can always encourage the patient to consume food sources of these vitamins. So the richest food sources of vitamin D provide only a small percentage of the recommended daily intake of 800 IUs of vitamin D. Very few foods contain vitamin D, but these are the flesh of fatty fish, such as salmon and tuna, and fish liver. There are some foods that are fortified with vitamin D, such as milk, orange juice, and breakfast cereals. In combination with increasing your intake of vitamin D-rich foods, you can also choose to put a patient on a vitamin D supplement. So vitamin D3 has been shown to raise serum concentrations of 25 OHG better than vitamin D2. The typical vitamin D replacement requires at least 2,000 IUs per day, with some authors in the literature suggesting 5,000 IUs per day. For Mr. M, he increased his intake of vitamin D-rich foods, and he also was given 100 micrograms per day, or 4,000 IUs per day, of vitamin D3. We plan to check his vitamin D level in another 3 months to see if these strategies are help restore his concentrations of vitamin D. Finally, we can look at treating Mr. M's vitamin E deficiency. So of course, you want to recommend foods to these patients that are high in vitamin E, such as dark leafy greens, almonds, red peppers, avocado, wheat germ, sunflower, safflower or corn oil, peanuts and peanut butter, and eggs. The only form of vitamin E that is recognized to meet human requirements is called alpha tocopherol. So this is the oral supplement. If you're going to recommend an oral supplement for vitamin E, you'll recommend the alpha tocopherol. Mr. M was placed on this. He received 1,000 milligrams per day of the alpha tocopherol, and we plan to recheck his vitamin D level in 3 months. Standardized adult treatment for vitamin E deficiency ranges from 200 to 2,000 milligrams per day of the alpha tocopherol. So in summary, we just want to thank you for following along with us on Mr. M's journey of macronutrient stabilization and his TPN to finally reach weight gain and weight stabilization. Sometimes it takes several adjustments. And also, we reviewed troubleshooting tips for low levels of micronutrients and how to manage these in patients on long-term home parenteral nutrition. We hope to see you next time.